And we're going to finish the morning with the following discussion. Can we reduce inequalities? And now I'm calling on John Dieberg, Claude Evin, and the debate will be moderated by Francis Brunel. Good morning. So you had a croissant. I think you can manage to wait until lunch. And so it's a great pleasure for me to welcome Mr. Dierburg-Wittram, who's the father of the concept of measurement of health outcomes. So we're going to give him the floor first, and then Claude Evin. Let's just look at healthcare inequalities, because the goal is obviously to find a solution to reduce these inequalities. Maybe we could recall that in the determining factors of health, which are measured perhaps rapidly by premature death, 40% are the result of individual behavior, 30% are inherent to our biology and our genetics, 15 to 20% depend on the social context in which we live, and only 10% are in fact determined by the healthcare system that we are entitled to. So this means today that healthcare policies, which represent a large share of the GDP, when you look at the healthcare system, this healthcare system is only a determining factor in 10% of our condition of health. This morning we heard a certain number of comments, and this is the spirit of Sham. People are very honest, and one word that we heard several times that struck me was confidence or trust. Obviously, we even said you could purchase trust. So the contract between one healthcare system, the doctor and the patient, or the doctor and the population, is a contract. You purchase trust, and these are not my words. We also see that we need to assess the system in one way or another, even if we assess the means to measure the efficacy of the system can still be debated. This capacity to measure the efficiency of the system is in everybody's mind. And I'd just like to add one last word, because as you know, I'm a neuropediatrician at the Necker Hospital for Children, and any measurement that seems very intelligent or efficient, such as that campaign in France where we said antibiotics are not automatic. It was quite a rock and roll, quite a sexy TV campaign. We at the hospital see a lot of cases of cerebral abscess linked to the fact that people don't treat sinusitis, and this leads to complications that we never saw in the past when people were taking more antibiotics. So every new measure has impacts. James?
Tell us about what is the outcome measurement. Thank you. Bienvenue.
Sure, thank you very much. It's a pleasure being here, and actually I've never been introduced so kindly as a father of outcome measurement, which I'm definitely not. I would probably call myself rather a member of a growing group of people who believe that the concept of systematic outcome measurement is important in order to achieve equality in healthcare and to make our healthcare system sustainable. So when I joined the CHARM meeting this morning and we heard so much about inequality, I had a little bit fear that this will be a discussion about how do we help poor people getting access to the healthcare system. And this is definitely an important piece of the inequality problem we are facing. But I want to tell you that even in countries where healthcare systems are organized in a different way and the inequality problem might not be as big as in France, we have to deal with significant inequality. And this is inequality to good care, inequality in access to good care, to appropriate care. Appropriate care means the right treatment at the right time, by the right person, in the right place. And in this sense, most healthcare systems in the world are extremely unjust or unequal. And sorry that I have to rock your boats a little bit now. This is also true for people like you. This is also true for the privileged people. This is also true for the well-off people in Paris who might know where the best place is to go to. In fact, they don't know. And we see in countries where outcome data are available that very often the people who believe that they have more information, better information, that they have access to better treatment, they end up with a severe overtreatment. And overtreatment means too much back surgery, too early hip replacement, too aggressive treatment of things that can be done much easier. And I would say most of you belong to this club, as much as I do. So when we talk about inequality, we are not only generously solving the problems of poor people, we are talking about ourselves. So what is an outcome, and why is outcome measurement important? Well, you know, I don't want to invite you to an academic lecture now, but I think I would like to take the opportunity to define this for you. An outcome is a medical result that matters to patients, full stop. What does it mean? It means that with every medical condition, there is a certain set of outcomes that is typically in the interest of a patient. For example, if you are diagnosed with prostate cancer, you are, as a patient, generally interested in the survival. But much more than this, you are also interested in your quality of life after treatment, since prostate cancer is one of the few cancers that can be treated very successfully. What about your incontinence after surgery? What about the bowel irritation after radiation treatment? What about the erectile function that is affected by around 80% of patients who receive prostate cancer surgery? What about anxiety? When you are maybe voting for a less invasive treatment and a active surveillance. These questions are in any and every patient's mind. And if you want to find data, how good is the hospital around the corner when it comes to incontinence? When you want to find data, how good is my doctor in dealing with anxiety? You end up with nothing. And that's a problem. So what we believe is that healthcare systems would dramatically change if we were systematically measuring the outcomes that matter to patients on a medical condition level over the whole care cycle. So not only for the 3 days in the hospital, over the care cycle that might start with a GP visit, that might end up in a rehab visit, or how long it ever takes.
Thank you. I think we'll go on this concept, and thank you very much. I think it's been said during the first roundtable that the patient is the center of your evaluation, so you put the patient really in the center of your problematic. Claude Evin, sur les inégalités santé.
So concerning healthcare inequalities, Claude, you have a privileged position. You are able to observe these inequalities. And you have come to the idea that these inequalities are not just social, but also territorial. And it's not that easy, really, to analyze them and carry out a diagnosis. I think that effectively, we've had lots of debates since the beginning of the morning, and we've just heard what our colleague has to say. So we need to think about the determining factors of healthcare. This is what you said in your introduction. the organization of the healthcare system is obviously very important, but it's not entirely a determining factor in terms of inequalities. The way you are treated, access to healthcare, measuring quality, systematic measurements, we've just talked about those. These are all things that have to be taken into account as well. Let me share my experience as a general manager of a regional health agency. These inequalities are there, especially territorial inequalities. In Haute-Seine, you live 2 years longer than in this area called Seine-Saint-Denis. So this is it's because of the RER train, is that what it is? Well, yes, this is something that we showed, that we published. We looked at the line 12 of the train. There are 4 extra years of survival, depending on whether you're domiciled around that line or not. But what we're also seeing is that there are differences inside specific geographic areas. In Voisin-Bourtonneux, people live 7 years longer than in Trappes. And if you're familiar with the geography of France, les Yvelines, we're talking about 2 areas that are side by side. So these are aspects that we should really be taking into account. And it's true that from this point of view, the regional approach, the approach of regional health authorities, I don't know what Jean de Kervazuet thinks, but the regional health authorities are allowing us to look into these things. We can take into account the entire healthcare problem, not just the question of the offer and how that offer is organized. So we're looking at the entire approach in a specific environment and a geographic environment. And this means that we can adapt to different policies. We can adapt policies in relation to the state of health in the Île-de-France because it's different from other regions. So we know that there are a certain number of differences between regions. Now, the question raised is, well, we've talked about these inequalities, these healthcare inequalities. How can we go from this concept, reducing these inequalities, to some kind of public action? We have made progress in terms of inequalities and our knowledge of these. There is the Marmot Commission of the World Health Organization. We've heard since the start of the morning how data can provide us with information so that we can build up the right kind of policy. So I think we need to agree. Access to knowledge does not solve all problems. We have problems that are technical. How can we build chains between this concept, including the social determining factors, the operational determining factors, when we've got system tools that are fairly rudimentary? Access to SNIRAM, access to different things in France are determining factors, but they don't give us any information about the social position of healthcare consumers. And then there are strategic difficulties too. How can we include the idea that these inequalities are of a structural nature? First of all, in the panel discussion, there were a certain number of errors underlined. For example, an error concerning an overall approach, whereby health professionals would cover all of the social and political field. Another error would be to not want to have any effect on these determining factors because they escape the field of action, the scope of action. And there are also inequalities linked to the healthcare system itself, differences that may exist, and even if they represent a low share of the determining factors for inequality in healthcare, they still need to be taken into account. And I would like maybe to make an exception to the rule given. I'd like to show you 2 slides, if that's okay. And I'd like to look at the prevalency of diabetes in the Île-de-France area. If you look at the brown areas, these are areas where you've got a high level of this pathology. And the second slide, if you look at it, it draws the link between what we see on the left, the Human Development Index. This is an index that looks at the state of health of the population, the level of education, and the level of revenue. And the red areas show us areas where the Human Development Index is the lowest, so below the regional average. And if you correlate this map with the prevalence of diabetes, you've got a juxtaposition of the two maps. And this kind of approach and access to information that we've been talking about this morning, these data come from the SNIRAM organization. So these data allow us to adapt a response to make sure that the solution is adapted to the region. In the Ile-de-France, you're going to have a policy that's going to be different because of the prevalence of diabetes. So you're going to target in that area that you see here. We're going to target that area so that with all of the people involved in the area are aware of the problem. Julien Legrand was saying this, talking about service collectors. How do you get everybody in the area to be involved? All of the professionals, people working in establishments, patients associations, how do we all work together so that we have the right kind of targeted solutions in relation to the knowledge that we have of the area? And we'll talk about this new discipline that is emerging, which is called the geography of health. As Assistant Mayor of the Saône, with the Association of Mayors of France, and we are looking at this problem together with elected officials. Now, Jens.
Outcome measurement can influence the organization of the territories in a country like yours or France. How come the measurement of the effectiveness or efficiency of the system or outcome from the patient point of view can influence the reorganization and can actually address those inequalities that are very, very difficult to analyze?
Yeah, it's a good question, and you know, since you are speaking about the region you are responsible for, a region comes in my mind that might be an interesting comparison. And I'm talking here about the region of Stockholm, which is the largest county council in Sweden, covering around 4 million people. So it's not so far away from you know, what you are facing most probably. So Sweden is a country that has a long tradition in systematically measuring outcome data for various medical conditions. And these outcome data are collected in national registries. And at least some of these data are available to the public. So this is something we, you know, might consider as a solution for Paris or for other regions here in France. So what is happening? First of all, and I would like to start with probably the most important aspect. First of all, doctors know how good they are, and doctors know where they have to improve. What I love so much about doctors, and I'm one myself, what I love most about doctors, not that they're all great. I love that they want to be great. Typically, they already wanted to be great when they went to school and at university, and we can leverage that. So if you provide a doctor, and I include here all other clinicians as well, if you provide nurses, therapists, psychologists, physicians with data about their patients' outcomes, they are moving, they are changing. This is in the nature of the profession. So what we see in an area like Stockholm, that there is a tremendous change in care provision, that physicians are adapting the processes, that they sometimes give up what they did and give it to others. This is something that needs to happen. So transparency in order to drive improvement. Secondly,
Jens, vous avez confiance en l'homme, you trust people.
Yeah. Well, you know, when I talk about outcomes, I talk about reliable data, scientifically improved data that are systematically collected by scientific methods. And this is a way how the national registries work. In the areas where we have these things established, there is no doubt about the quality of the data. Secondly, this was mentioned earlier, there is an element of patient choice. Some patients are good in leveraging those data, using these data in order to find what is the best doctor for me, what is the right hospital for me. And unfortunately, and now I get back to the first level of inequality, this is not true for the most vulnerable parts of our society. The less educated people have a disadvantage in interpreting data around quality, but they have referring doctors, they have GPs, and for them it's good to know what is the best hospital to take care of my patient. And ironically, in the movie that has been shown at the beginning about the 3-star hospital and the 5-star hospital and so on, this is reality. In the United States, the Society of Thoracic Surgery has an agreement with Consumer Reports, which is a huge platform of consumer information data that is subscribed by 70 million people, a whole population of France. And they are rating all the thoracic surgery institutions in the US with stars. There are 1-star, 2-star, 3-star cardiovascular surgery departments in the US. This is available publicly. And this star rating is based not on patient experience or fancy recommendation by colleagues. It's based on outcome data that have been calculated by Duke University. Third and last point, we have to think about the reimbursement. Today, health plans, and no matter if it's a private or a public payer, if it's a single payer system or multiple payers like in my country, we are paying our doctors, our hospitals by volume, by procedure. The more hips you put in, the more money you make. The more x-rays you take, the more money you get. The longer the rehab stay, the more money you get. This is a wrong incentive. And if we don't control that, and by the way, France is trying to do that by a global capitation. If you don't do that, you end up like the US system. It's a wrong and a failed system. In Stockholm, and some of you might be shocked, but it's simply reality. In Stockholm, they agreed last year to reimburse back pain surgery treatment with a performance bonus. And this performance bonus is calculated in a very simple way. 6 months after surgery, every back pain surgery patient in Stockholm receives a letter from the National Registry, not from the hospital, from the National Registry, and asking simply the question, how is your back pain compared to prior to the surgery? And depending on the result of this question, and by the way, behind that is a very, very complex algorithm leveraging the data of the National Registry, 100,000 of data. Depending on the result, you can receive up to 40% of your whole revenue by the quality you achieve. So in the best case, you get 20% more. And if the patient says, well, surgery was great, everybody was nice, room was large, food was good, nurse was sweet, doctor was very, very nice to me.
But
no infection, but unfortunately there is still this pain. You lose 40% of your revenues. 40% of your revenues. That means you end up not only without any profit, you will run into the red figures. This is reality of reimbursement in Stockholm today.
c'est une prime variable.
And
It's a variable bonus.
you might also be lucky sometime, but it's reality today, and it has been so successful. The pilot started in 2009 that they are doing the same now for 8 other medical conditions, including breast cancer, including stroke, including diabetes.
Thank you very much, Claude. Pourrions-nous parler peut-être maintenant de...
Can we talk now? Thank you, Claude. Can we talk now? Well, we saw the map earlier on. We've talked about this new discipline based on health geography. And I belong to an association Élus Santé Territoire, and we're working with the University of Nanterre. We've been working with the university for a while, and we're realizing that there are difficulties that we didn't even imagine in terms of breast cancer screening, for example. We realize that if there's a railway that separates one residential area from the medical center, the screening rate drops. There are territorial organizational elements involved. Perhaps you could talk to us about this, tell us about what you think and how we can improve this.
Well, I think that if we do have this goal, and everybody's been talking about their concerns of reducing inequalities this morning, I think we've got to have targeted policies targeted on specific populations. The goal being to provide a response that will enable these populations that are in the greatest difficulty to get back into the system. And also, I think that we need to have a response that is suitable for different specific features in France. That means that we've got to have the means, and I think that we're beginning to have them, although the satisfaction indices based on databases that I can't describe in detail. But we are beginning to have tools that enable us to identify the epidemiological situation or behaviors. And you referred to the work done in Nanterre on geolocation in the screening of cancer, which should lead us to policies that are different according to where they're applied. I think we can have main principles because that will enable us to see what we're heading for according to what we do. But according to the health system, which differs from place to place in the country, we've got to see what the response that we give to Madame Durand in Provins, which will be different to the one we give to Mr. Durand, who's in the 16th precinct in Paris. We've got to have a suitable response. But the difficulty is that we're working in a system that's not organized to do that. We have a system that is very walled up and is going to remain walled up between prevention, health education, the offer of care, which is organized differently according to whether you're in the liberal system or going to a hospital. And even in the hospital, we have some difficulties. The separation between the health and social sectors is another feature. And the fact that we have, I'm not going to go into all the details because you all know about this. Everybody knows the system's walled up. But I haven't come here to sell the draft law of the government, but the concept of territorial service is important. This is something that is perhaps closely linked to politics, but you've got to have a diagnosis, make a diagnosis of the population, of the specific features of one part of the country. How are you going to set up a system for the whole of France and mobilize all the people, not only the healthcare professionals and the hospitals, but also the local authorities, the associations, patients' organizations and sports organizations, the associations, and even the health users around a project for health? I think the approach is something we need to invent. It's not something you're going to be able to set up overnight, of course, either. And we've got to build this up based on the reality of our system. And I think the experience that we see from abroad will also be useful to push us in our reflection and stimulate the way we think. But we can't always do things the same way as other countries because they have their background history and their institutions too. Today we've got to try and provide this response adapted to the population, not a response to the institution itself, which does have its own constraints, but the population and the people that are taken care of. Well, thank you for that. James?
Interesting, but it actually addresses single elements of the healthcare system: back pain, prostate surgery. We are talking about a global organization, and also, as we said with Claude, that you have sometimes some patient will have even difficulties to get to the healthcare system, because you can evaluate the healthcare system when the patient is inside it. how do you organize, what's your point of view, how actually to cover the needs, the healthcare needs for patients, population that actually will not go to the system?
Yeah, I think first of all, it's quite simple. If you want to give 60 million people access to healthcare, you need to keep the cost under control. One of the reasons why you have inequality in access in this country is driven by the financing mechanisms you have in place, and they finally lead to the decision of countrymen not to go to the doctor. So it's not only a matter of education, it is something that is particularly driven by the economic situation and the reaction of the euro crisis here in France. So access has been better before than today. So when we want to fix healthcare systems, we need to make them cost efficient. Cost efficiency is what we call a focus on value. So a healthcare system needs to deliver value, and value is best described or defined as the outcomes we achieve per money we spend. So you cannot necessarily say a doctor or a hospital who is working very, very low cost is good, because the outcomes might be bad. And you cannot say there's a hospital that achieves good outcomes is generally good when the costs are simply skyrocketing. So what we need is, we need the transparency. What is the outcomes we achieve for a medical condition, and what are the costs to deliver those outcomes? We believe, and we have data showing, that the more healthcare systems are driving into this direction, the less costly they are, because you are wasting in this country, as in Germany, as in UK, as elsewhere, you're still wasting a lot of money for repair business, for unnecessary treatment, for fixing things that have been missed. A couple of weeks ago, the OECD has published that France is number 3 in the whole OECD when it comes to deep vein thrombosis and pulmonary embolism after surgery. Number 3 in OECD, behind Poland, behind Belgium, behind England, behind Italy, behind Spain, behind Portugal, and so on. This is your data, and this is your reality. So here are a lot of hospitals in this country who are significantly producing complications. And someone is paying for that. We have to get rid of these things, not only to help the poor patients and the families who are suffering from these problems, but also to save money. When it comes to how to organize that, this is a great point, but I would like to extend the concept of a medical condition. A medical condition is not only helping a patient with prostate cancer or with a coronary artery disease. In the example you gave, the medical condition is that there is a huge population at risk for diabetes. And the medical outcome we want to achieve is to keep them away from diabetes, to keep them away from amputation, to keep them away from blindness, from kidney failure. And we have to measure that. It's not only the data that tell us that there is a regional distribution pattern or that there are differences in care practices. This is known for 40 years. The problem is that there are doctors who don't even know how good they do in managing the diabetic population they are responsible for. And that's the reason why they never develop the right measures how to deal, for example, with a group of less educated patients. So sorry for that. I always end up with outcome measurement. It doesn't help. We have to put the patient in the middle of what we are doing.
That's what you are invited for. Thank you. Claude, on a vu dans les...
Claude, we've seen in the previous conversations during this morning that regulation or triage is important as well. We quoted the remarkable organization of how acute cardiovascular events and strokes are cared for. And there's something very specific in France with the organization, the way we organize our emergency department, the SAMU. And there are also the specialties that participate in that. You've got the neurovascular surgeons and the cardiologists. As far as the triage system they use at SAMU, can you tell us how it works? Can you tell us if it's easy to set up this regulating system? Well, it's very provocative. I was telling a story the other day, but before I go on and tell the story, to conclude, perhaps I should say that I believe that you can, in this sort of colloquium, talk about a certain number of fairly general ideas. And there are bottlenecks. There are points where the system blocks. And I think that you've got to start off from something real. And the reality is that we're in a system, as I said in my previous talk, we're in a social system which is fairly rigid. And I think we're only going to be able to change it if we take into consideration that reality. I'm reacting as a politician, of course, not just as a civil servant and somebody who runs an administration. But I think you've really got to take into account that reality. You've got to take into account all the players in the institutions we have today and see how we can change things in the future. Nobody is challenging the medical convention or the relationship between the high street doctors and the health insurance fund. But we've got to change things so that we get better quality. We've got to make sure that the goals are achieved. These goals don't always respond to the needs of quality. We're not going to just pay the doctors per procedure and the volume of work they do. The changes maybe don't happen quickly enough, but things are moving. And since we know what reality is, we can base what we do on reality and go a little further. The story I was referring to earlier and that Francis wants me to tell it does show that too. Yves de Prost was saying earlier that regulation triage is important. In the Ile-de-France region, we have done quite a lot of work over the last 2 years to associate the high street doctors and the emergency service to organize the system to act as fast as possible. And the idea is, before you do anything, call 15. We've a communications campaign, which is based on posters and other things. Before you move, call 15. I don't seem to be able to mobilize the high street doctors and SAMU to get things together on the following point. If you call 15, then somebody answers you and says, SAMU Center 15. And the SAMU doctors don't like that, and they can't agree on it. The message that the patient gets is not the right one for them. What they would like them to say is, this is the triage center. And they say, well, we don't really feel that this campaign is suitable, so we won't invest in it. You've got to take into account all these factors. And, of course, it's not that I cross with the Doctors' Union for saying that, but every day there are little things like this. And you sort of think to yourself, well, this is something we ought to do. There are rules, there are legal rules, constitutional rules, cooperative rules, and we need to work differently with the insurance funds as well. We're getting to it. Not quickly enough, but I think we'll get there eventually. Thank you, Claude.
Just a word of conclusion after a close conclusion.
Yes, sure. I mean, we spent the morning to talk about the data sources that are available in your country. And as a matter of fact, you have a lot of data. It's a treasure, something you can use. If the OECD can report on the level of sepsis and the level of pulmonary embolism in your country. You can do it yourself. You can do it on a much better level. You can do it on a hospital level, on a level where it really drives change and improvement. I don't know if this is appropriate for a German to say, but I would like to invite you to start a revolution, a transparency revolution. And it basically would be the second time that a revolution in your country is changing the rest of the world. Thank you.
Thank you very much. Merci beaucoup. Merci Claude. Merci Jens. Bon appétit.